Welcome to our webcast, and I'm Caston Thomas. We'll be spending time with Kevin McDonald today, and just a little bit of housekeeping. There are two buttons at the bottom of your screen. You'll see a chat button and a Q&A button. Feel free to chat with your peers. But in addition to that, if you could post any questions that you might have on the Q&A, please use that button. The session will be recorded today, and we will be emailing you with follow-up to that. And we have about 200 people registered for this webcast. So we're limited to 30 minutes, and we'll be also separately emailing you a list of those questions with Kevin's responses to that, along with some show notes that I'm sure you'll find very, very effective. We respect your privacy and your time, so we're not going to be overloading you with responses. We will give you an opportunity in in all of the emails that we follow up with you to be able to opt in for notices on Kevin's blog entries, as well as future interviews and webcasts being done with Kevin and by MedSec. So we'll also include a link to a survey, not to say what you liked about this session, because I know it's going to be outstanding the time that we spend with Kevin, but we really want feedback on what you'd like to see in future webcasts with Kevin. So to introduce Kevin, he spent 40 years in healthcare, all of that time in hospitals. Interestingly enough, I learned that Kevin was the only male student in his graduating nursing class. He began his career with a small hospital as a nurse and transitioned into his career as an instructor, as a director of nursing, and eventually as an IT project manager. He joined Mayo in 1999. In 2013, he was asked to start Mayo's medical device security program, and he spent 6 years leading the development of that program and into what it is today. So there's a lot of experience, a lot of insight that he has, not just from that, because going on 2 years, Kevin began working with MedSec, and he has spent his time in advising other hospitals with a wealth and breadth of differences in the needs of those hospitals, and we'll be touching on that, helping them, advising them on creating their own medical device security programs. So a couple of interesting things: when Kevin isn't taking care of improving the lives of patients and caregivers, he loves to go camping, particularly out in the Midwest. He does that in his RV with his wonderful wife and his dog. And he's also climbed both Mount Rainier and Devil's Tower, and I'm insanely jealous of that, Kevin. And if any of you have ever attended any of his presentations or sessions at HIMSS, at AIMS, other places where he's presented, you're here because you know that Kevin's perspective is insightful and delightful. So Kevin, thanks for joining us today.
Sure, and I still have, that was back in the days of nursing caps, and I still have my nursing cap, but they didn't make me wear it.
You could put it on at the end of today's session.
Yeah.
So let's hop right into it. Looking back over your 8 years of experience specific with medical device security, what's the hardest thing that you found hospitals and the leadership and those directing the programs have to overcome in establishing a program?
The initial thing really is much more of a culture and an awareness of the risks that there are, as well as, everybody thinks of these medical devices, you buy them and you plug them in, and then they're sort of like this fat black box. Most people who are looking at the risks of these and who are looking at, cybersecurity don't realize that inside of that medical device black box is a computer running Windows ME. And And so it comes as quite a surprise. And then comes the thought that, well, since they're on our internal network, we're good. And so it's really getting awareness of, yes, there's a lot of technology out there. That technology is not good. The second hard part about this, and I think the thing that really resonates when you go and you talk to healthcare providers is that, um, this is really you need to frame this not as a technology issue, not as a cybersecurity issue, but as a patient care and a mission, vision, values issue.
Mm-hmm.
There's a huge difference, and people are thinking, oh, okay, we got ransomware in one of our computers, so we'll just throw that out and get that in another one. They don't understand that if you have, ransomware or some kind of compromise on your CT machine, and particularly for small hospitals, that's the only one they have, that has some potential to lose huge revenue and impact patient care. And it also has, depending on the device, has the potential for patient harm. So you really have to go into it with that. If you come in and say, oh, if you tell your clinical leadership and the people and your chief financial officer at a hospital that this thing that sucks because it runs Windows ME, uh, that's okay. They got a bunch of that stuff and they aren't quite so sure actually what that means. So you got to peel all that back.
Right. And so in that peeling back process, is there a foundation or a base of work that's important that leads to the successful outcomes that you're defining?
Um, there's to be able to really lay that foundation, and I'll be honest with you, Caston, is there's some institutional foundations that have to be in place as well. So
Mm-hmm.
if your institution doesn't have a pretty good capital equipment purchasing process, your ability to be able to onboard and intake, medical devices is going to be really tough because you need to have that consistency across the institution. So it's those, across the board institutional things. The second thing you really need as a foundation is a governance group, and that governance group should not be led by your CISO or your CIO. It should be led by somebody who, again, going back to the impact on patient care and potential for patient harm, it should be led by a clinician who has a broad overview of your institution of healthcare and the impact of technology on it. The ones I worked with in the past that seem particularly well suited are radiologists, because quite frankly, they're heavy into the equipment. They have
Mm-hmm.
much more of a technical bend, and they know if the CT or MRI goes down for a day, one, that's $1 million potentially for a large institution, and two, you're going to disrupt patient care flow. Um, the other, groups that I've worked well with are really some of the intensivists. Again, they're high equipment and they can close their eyes and imagine their last shift in the ICU and seeing the monitors, what happens if the monitors go down, what happens if the IV pumps are compromised, those types of things.
Mm-hmm. Mm-hmm.
So
So there's a lot of functions and a lot of moving parts just organizationally. Is
yeah,
there a particular part of the organization or an approach that you found for a hospital to assign responsibilities and build that collaboration across the different silos in the hospital?
some of that depends upon how your institution is set up. For those of you out there who work in hospitals, you know that they love a committee. And so you need to find somewhere high enough up into your committee structure to be able to integrate this work into them. Uh, if you can get high enough into something like, it can be called the patient care committee, it can be called the medical executive committee, and you're required to have one for joint commission.
Mm-hmm.
That's the area that has a broad enough reach over clinical care, which then gives you the ability to start integrating across multiple areas. And once you have that across multiple areas and you have enough of that clinical input into that and um, clinical backing, it makes it even easier to go back and now start talking to your supply chain managers and that. It's also really good too to be to get that in place, because then it provides a buffer for physicians who potentially in the past have been able to uh, see something in a conference and bring it home under their arm, or order it and next thing you know it's theirs because it plugs in. So there's a real feeling, and quite frankly a real loss of control amongst some of those physicians that are involved and the other people who are making the decision making. And so being able to institutionalize this and being able to have those decisions made at a high enough level by somebody who is um, within that clinical area really just makes the huge difference. It's not, security gets lumped into with IT and everybody hates IT. And so it makes a huge difference.
And there's also not a lot of fondness of the cybersecurity group either. It seems like they're always the guys saying no.
Yes.
So let's step back. With your experience at Mayo and the wealth of knowledge you've acquired since then, what would you consider the biggest accomplishment that you've witnessed as far as achieving a high level of maturity in a program?
There's a couple. One of them is that you have the program integrated across all of the current processes in your institution, everywhere from budgeting, acquisition, all the way through to what you're going to do for end of life. And so the experience most people have, if they have some type of capital equipment committee or something at the institution or if it's run out of the purchasing department, you'll find that they have a stack of stuff and they have to have a list of things that they need before they can purchase anything, a quote, they may see, a revenue anticipation, those types of things. And so your cybersecurity assessment should be one more on that checkbox as you go down. In the contract for purchase of this, you should have all of the standard things that are on your medical device contracts, but you should have a section there that is medical device security. Right. As you're doing your annual budget planning, you should have built into there which one of these things can no longer be updated, what kind of end of life. So if you can build that whole thing in there, then it just sort of becomes running. It becomes institutionalized.
Mm-hmm.
You also are able to pull in your biomed people into that as well, as far as input, because you're going to want to be able to, again, institutionalize this so your remediations and mitigations are pre-planned. And so all your biomed, your HTM people have to do is to just follow those instructions for all the norms, and then they can devote time to the things that aren't the norms.
That's really a good point. And the way I would interpret that is a key component of the ultimate outcome is that you eliminate the responsibility or the job that you assumed, because you're integrating the processes and the task into the normal business operations, so that cybersecurity of medical devices doesn't stand alone.
Yeah, but by the time, if you've really matured this program, and we were able to do this as well, by the time you really get it integrated, you actually need less staff than when you started. Because you've taken, initially I was doing contract negotiations, which was not the most efficient use of time. But by the time we were done, there was somebody who had done it enough with us that they were doing the contract negotiations.
Right. And that just became a part of the normal contract negotiations.
Part of the normal contract negotiations. We didn't have to individually look at what mitigations or remediations to do in a device. We had a list of what the vulnerabilities were, and along the top were our mitigations. And so those were all pre-built and discussed. So those were then able to just happen.
Mm-hmm.
And so then it just runs in the background. If there are things that are odd, there's always going to be something you're going to want to buy that truly sucks, but it's going to save a dozen babies next year.
Right.
And you should buy it, because it's within your mission and vision and values. Now you can spend some time on how you're going to take care of that and manage that, as opposed to just the 80% of the other routine bad stuff.
Yeah, we've got some great questions coming in, so let's make this about our audience. Is your suggestion that a medical device cybersecurity governance entity be a subcommittee of the PCC or of a similar group?
It should be a subcommittee of the PCC.
Mm-hmm.
Because you're going to want to go to your patient care committee on a monthly basis. You're going to want to provide them written statistics or dashboard and metrics. And then that then gets included into their packet, which then goes to the board. You also are going to want to go sort of an end run, as well as when you have your risk dashboard and your metrics that your CISO then brings to the board as well. You want to have it in there. So you want to be able to get all the way up to and having your metrics part of the board responsibility. The CPC is a committee that will look over all the medical care and is responsible for all the medical care, or the PCC, depending upon what you call it. And so that one really needs to stay fairly clear, but you need to be able to ask that group for assistance if needed, and they're a high enough level, you won't have any problems.
And in doing that, medical device security becomes a part of the overall patient safety model.
Yes.
Yep. Cool.
And,
so,
sorry, and as you're doing this, most of those patient care committees also have somebody in there from risk as well. This should just flow right into your risk management program for the institution as well. So when they're starting to look at what our biggest risks are this year, you want to make sure that you have provided enough evidence that out of your top 5 risks for the institution, top 10, that medical device security is one of those.
Yep. So next question, and I'm going to add a little bit to this question, but what do you see as the most challenging area of building the full life cycle phases? And my add to that is I've seen a diagram that you've published of the 8 pillars of a medical device program. Could you talk about that and then talk about the difficulty of those stages?
I think setting up and having a good governance is the hardest. Because I can't
it was critical up front, right?
Yeah, and I can't buy a tool. I can't, flip a switch. I can't enable a new functionality. I got to deal with people. And for those of you in technology knows that's the hardest part of our job. So that's hard. Kind of secondary to that is just the awareness. We had a big we got a big jump coming into this of where we brought in a bunch of people to do some testing on 40 plus devices. And, when we owned them all, we compromised them, bricked them. And so that gave us some evidence back then. I don't think you need that amount of evidence now. So that's the hardest one. And believe it or not, the other hard one is end of life.
Yeah.
There is stuff out there which works perfectly fine, does its job, but just sucks from as far as cybersecurity. I mean, just horrible.
Legacy devices, right?
Yeah. So part of that testing we did, we loaded Pong onto one of the machines, and the hardest problem we had was finding a version of Pong old enough to run on it. And that getting an institution to start thinking about a CT machine that still works, still brings in cash, and still meets their requirements, but is so old it is cybersecurity bad. It's really hard to start making those financial arguments, and that's some of the most hard discussions, because everybody wants to buy new as opposed to just replace the current junk they got.
Right. And you've done a lot of work in all of these 8 pillars, and we'll send that out as a part of the show notes. But this question came in actually before today's session. Is there information or resources that help an organization establish a program? Where's your go-to resource?
There's a couple of places. One obviously is the resources I have. which is a lot of the stuff that I've developed over the years. The second one, if you want to have some jumpstart some and take a look at the Mayo program, it's actually open sourced on their public website.
Right.
And so there's examples of contracts there. There is some examples of vendor letters and steps to go through. So that's a great place just to get started and start digging around at.
Example workflows, example incident response, technology evaluations.
Yeah, that's not on that site, but there are some things about the evaluations. There's data collection from the vendor. There is information there about some mitigations, and so it's a great place to really start pulling some materials and start getting a better idea about the full life cycle.
Well, I'm going to put you on the spot here. There's 163 people listening, so you're on the ticket. Why don't we continue these interviews, because we're close to being out of time? Would you agree to do 8 more sessions like this periodically on those pillars, and we can really drill into each of those. Drill in as much as you can in 30 minutes. So, oh, I got a head yes. So fantastic. We got some really great questions. I'm sorry we're not going to be able to get to all of them, but here's one of my favorites. Let's agree that there's nothing 100% secure. So my question is, how can you deal with a sophisticated cyber attack on one of the critical medical devices, which causes a crisis, possibly even a loss of life? Ouch.
Yeah, well, this is part of the foundation of is that you're right. You're never going to be 100% secure.
Mm-hmm.
We've just seen that with the SolarWinds. And so you have to tailor your program to your institution's risk appetite. You have to tailor it to your ability to resource it. You have to tailor it to your ability to fund it, as well as you have to be able to bring the risks to your governance structure of what it would cost and what the potential impacts are. And you have to let the institution take that risk acceptance. So the example you gave is, if we have something that's just horribly bad, we know it, and we know that something's has a higher likelihood of being compromised. We'll go through the mitigations, we'll go through the remediations, what it's going to cost, how much risk we're going to get down. And then we just bring it up through our governance structure of, okay, either you as an institution have to accept this risk,
mm-hmm.
and then we get to walk away. We still do our best to make sure we maintain everything, but that's a known risk. Or you either have to buy something different, you have to fund additional infrastructure for our network, fund some more monitoring to be able to bring that risk down. And that's a very empowering feeling if you're working there, to be able to have the institution take that risk, as opposed to you running around wondering if you made the right decision.
Yeah, for sure. I'll throw in one of my pet peeves is creating that culture of collaboration of the network group, the biomedical group, the contracting group. I've seen too many times, not necessarily cybersecurity, but any level of downtime, the first knee-jerk reaction of some organizations is to say, it wasn't me, it wasn't us.
Yeah.
And you build that kind of culture, so you're pulling the best of everybody into that incident response piece of it. So one more question and we'll wrap up. We've got about 3 minutes left. Let's see. Here we go. What do you tell the hospital or the system that is willing to ignore or delay the implementation of a cybersecurity program to protect their networked medical devices? That comes back to people skills, I would guess. Here
is where you need to be able to provide the evidence of what's going on there, of what the risks are. And then you need to start working that up your, up the route of your CISO, maybe up the route of the CIO, as well as risk. And again, this really is your job, is to make sure things are visible and transparent.
And I would add, do it in a way so that the executive leadership doesn't roll their eyes when you walk in the door going, oh no, the sky's falling again.
Yep. And it's really, it's objective evidence as opposed to emotional evidence. And once you've done that and you've taken that up, if the institution then decides not to do anything with it, that's on them. And quite frankly, if you have an institution which is just ignoring it all, you probably don't have a great work environment to begin with.
Hope and what's the saying? Hope and I told you so, or not a strategy.
Yeah.
So to wrap up, the final question along those same lines is, what's the impetus that you find that really motivates executive management to take that initial move to do those first steps?
There's three things. One, patient care.
Patient care.
Two is loss of revenue.
Revenue loss.
And three is public perception.
Great. Somebody write that down, because that's got to be in the show notes.
And yeah, there's a whole nother thing in there about who's on your board and whether you can, get them involved too. But that's really it. If you're the CEO of a hospital, those are pretty much the three things. Well, four is finances.
Sure.
But
sure.
That's pretty much it.
Well, Kevin, I appreciate you spending time with us, and I appreciate everyone else who's joined us today. Just real quick to reiterate, this has been recorded. We'll be sharing that link to you, and feel free to share that with you and your peers. We'll also be answering questions in a follow-up email to the ones we weren't able to get to. We're going to respect your time and privacy, so if you want to opt in to further emails after the first 3 or 4 that we send you, you'll have an opportunity, but we're not putting you on a list. We're not sharing this with vendors, but we really, really appreciate the time you spent with us today, and wish you, until our next interview with Kevin, all our best. Thank you very much.
All right. Thank you. Thank you, everybody, for attending.